Welcome to the deep dive. Today, we're jumping into a really core topic in vascular surgery. Lower extremity chronic arterial disease, LECAD.
Right.
Think of this session as, well, a focused instruction manual. We're pulling the essentials straight from Rutherford, section 15.
Yeah, specifically chapters 107 through 115. We've tried to, boil it down to what you really need to know.
Exactly. So diagnosis, the different treatments, open surgery, endovascular stuff for arterial and infraguinal disease.
And amputation, too, when it's unfortunately necessary.
So whether you're deep into your career or just starting out, the aim here is a clear, practical overview, no information overload, just the key takeaways.
We'll hit the epidemiology, who gets this, why the classification systems like Rutherford, treatment options, outcomes.
And those crucial amputation considerations. Rutherford covers it all, really.
It does. Epidemiology, risk factors, global, U.S., specific how we classify it, treatment choices, results, amputation techniques, post-op care. It's all in there.
Okay, let's get started. Section 1, understanding the landscape. This is mostly Chapter 107 territory, right? It sets the stage.
Precisely. You can't treat it if you don't understand the scope. So prevalence first.
Right.
Globally, figure 107.1 shows it increasing by age, and notably, it went up between 2000 and 2010. That's in high-income and low- and middle-income countries.
Both groups saw increases. Interesting.
Yeah, and then in the U.S., figure 107.4 breaks it down by age and ethnicity. Big differences there.
Okay.
You see higher rates in African-American populations, American Indian, compared to, say, non-Hispanic whites or Asian Americans.
So definitely not uniform across the board. Suggests access issues, maybe, or risk factor management.
Could be a mix of things. Healthcare access, how risk factors are managed, maybe some genetic components too. It really highlights the need for, targeted approaches.
Makes sense. And the risk factors themselves, figure 107.3 lays those out.
It does. The usual suspects are there. Age, being male, hypertension, BMI, diabetes.
Smoking, of course, past or current.
Huge impact. Cholesterol levels too high total, and surprisingly, high HDL shows up. Plus, existing cardiovascular disease, C-reactive protein. It's a multifactorial picture.
And how does it actually present? Chapter 107 talks about the clinical side.
Right, it's a spectrum. Some people have no symptoms at all. Others end up with critical limb-threatening ischemia, CLTI.
Which is where the Rutherford classification comes in, table 107.3.
Exactly. That's our standard language.
Yeah.
It goes from category 0, asymptomatic, through mild, moderate, severe claudication.
Then rest pain, minor tissue loss.
And finally, category 6, major tissue loss. A key point the chapter makes is that if the disease is only in the infrapopliteal arteries, you might not get that classic claudication pain in the calf.
That's a good point. So for those who do get claudication, how do we assess severity?
Often by the initial claudication distance, how far they can walk before pain starts. Treadmill testing gives objective data too.
But it's more than just walking distance, isn't it? The chapter mentions functional impact.
Definitely. Lower limb strength, balance issues, general mobility loss. It all ties into the PAD severity, the ABI level, but also age, race, socioeconomic factors play a role.
Okay. And then the severe end, you mentioned CLTI. That term replaced CLI, right?
Yeah, critical limb-threatening ischemia is a broader definition now, includes neuropathy more explicitly, and it recognizes that there isn't one single critical perfusion number that applies to everyone.
It's more complex than just flow.
Exactly. Ischemia, infection, neuropathy, they all interact. And it's crucial to distinguish CLTI, which is chronic, from acute limb ischemia, ALI. That's a sudden emergency.
Right. Very different management. Given how serious CLTI is, are there ways to predict outcomes? Chapter 107 mentions prognostic models.
Yes. Table 107.2 lists several models trying to predict mortality or major amputation risk. They look at things like age, kidney function, heart disease, diabetes, tissue loss severity, frailty.
A lot of factors.
Yeah. But it's important to remember these were mostly developed using data from patients who got revascularized. So their accuracy in conservatively managed patients might be, well, less certain.
Good caveat. The chapter also points to guidelines like the SVS ones.
The SVS practice guideline for asymptomatic PAD and claudication, plus key papers like Creaky and Aboyans on epidemiology or Deem et al. On risk factors and atherosclerosis patterns.
And the WIFI classification.
Yeah, the SVS lower extremity threatened limb classification wound, ischemia, foot infection. There are studies validating its use too. And the chapter wraps up by stressing the ABI's importance, not just for PAD itself, but as a predictor of wider cardiovascular events.
Okay, solid foundation laid. Let's move to diagnosis and initial management. Section 2, pulling from chapters 108 and 111. Where do we start?
Well, the first principle really emphasized in Chapter 109 is being selective with imaging.
Don't just scan everyone.
Right. You only do more imaging once you've weighed the risks and benefits and you've actually decided intervention might be needed. Avoid unnecessary tests.
Pragmatic. So when intervention is on the table, what imaging do we use for planning?
Chapter 109 mentions the main ones: duplex ultrasound, CCA, MRA, and traditional arteriography, although Chapter 108 goes into the technical details. For aortoiliac disease specifically, Chapter 111 applies these.
Let's focus their aortoiliac evaluation in Chapter 111. What are the indications for intervening?
Well, obvious limb ischemia is one, but also maybe in younger patients with really limiting claudication, or if there's evidence of emboli coming from the aortoiliac segment.
Or improving inflow for a downstream procedure.
Exactly. Chapter 111 also notes there are contraindications, but doesn't detail them right there.
And before imaging, you need that anatomical understanding task key classification.
Precisely. Chapter 111 stresses knowing the anatomy and the task key system for lesion complexity. Evaluation starts with history, asking about hip, thigh, buttock claudication, impotence.
Then the physical exam, listening for bruits, feeling femoral pulses.
Crucial. And then the non-invasive tests, ABI, maybe toe pressures, treadmill tests, give objective data.
Okay, so after that initial workup, if aortoiliac disease looks likely and interventions considered, what's next imaging-wise? Duplex, MRA, CTA.
Duplex is great for hemodynamics. Check in the common femoral too. Good if kidneys are an issue, but can be limited by body size or calcium.
MRA also good for renal issues.
Yep. CTA gives fantastic anatomical detail, especially for calcium assessment. Really helps plan procedures, both open and endo. Diagnostic arteriography alone, much rarer now as the first step.
Right, the non-invasive options are so good. Chapter 111 also flags checking the common femoral artery specifically. Why?
Because significant CFA disease changes the plan. You might need a hybrid approach, open endarterectomy of the femoral artery combined with, say, iliac stenting proximally. Treat both effectively.
Makes sense. And what about lesions right near the aortic bifurcation? Any special considerations there?
Yeah, Chapter 111 mentions these are often bulky, calcified. Hemodynamic significance is key, not necessarily a perfect picture afterwards. And when treating endovascularly, you have to think about preventing emboli and maybe primary stenting or stent grafting to trap debris.
Okay, diagnosis sorted. Now for the treatment options. Section 3, chapters 109 and 111, open versus endo for aortoiliac disease. Let's start with open surgery from chapter 109.
The classic approach for extensive disease is still the aortobifemoral bypass.
Yeah.
Durable.
What are the key steps?
Midline or transverse abdominal incision, get to the infrarenal aorta retroperitoneal or transperitoneal approach, sew the main body of the graft on, then tunnel the limbs down to the groins and connect to the common femoral arteries.
And checking your work before closing is vital.
Absolutely critical. Chapter 109 stresses confirming good flow distally, no emboli. Feel pulses, use a Doppler. Then reverse heparin, irrigate, close the retroperitoneum, maybe use Omentum to cover the graft, and close the groins carefully.
What about long-term patency? What factors influence how well these grafts do, according to 109?
Generally, aortobifemoral grafts do very well long-term. Factors like gender or SFA disease, less consistent impact across studies.
Okay.
But what is clear is that adding a profundoplasty, fixing the deep femoral arteries, significantly helps patency and limb perfusion.
Good to know. Surgical approach or anastomosis type doesn't matter much for durability.
Doesn't seem to, no. Interestingly, one study mentioned suggested similar 3-year outcomes between percutaneous AIOD treatment and aortobifemoral bypass in some patients.
That is interesting. What about late complications, like false aneurysms? Chapter 109 covers those.
Yeah, anastomotic false aneurysms. Less common now, but they happen. Weakening of the suture line or artery wall over time.
Causes?
Could be suture issues, tension, poor technique initially, arterial wall problems, or low-grade infection, often staph.
How do they show up, and how are they fixed?
In the groin, often a pulsatil mass. Aortic ones might be found incidentally, or, rupture. General rules: repair femoral ones over 2 centimeters, aortic ones over 50% of graft diameter.
Repair usually involves?
Traditionally, open surgery, debridement, maybe an interposition graft, but increasingly, especially for aortic ones, endovascular repair with stent grafts is an option, less invasive.
Okay, that's the open side. Now let's shift to endovascular treatment for aortoiliac disease, chapter 111. This area has exploded.
It really has. Chapter 111 walks through the history: Dotter and Grunzig's angioplasty, Palma's stent, then better imaging, lower profile gear, pre-mounted stents, stent grafts.
And its role today.
Huge. Chapter 111 states the majority of patients with AIUD can be treated endovascularly or with a hybrid approach. It's often the first choice.
What are the main techniques Chapter 111 discusses? PTA, stenting, stent grafts, hybrid.
Yep, PTA balloon angioplasty, often with stenting, either selective or primary, for focal stenosis. Stent grafts are really useful for more complex stuff like TASI C and D lesions, or maybe treating calcified external iliacs during a femoral endarterectomy.
And hybrid.
Combining open, like the femoral endarterectomy, with endo, like iliac stenting. Optimize treatment, minimize the open part. Figure 111.8 shows a nice example.
What about technical points during the procedure? Access, crossing blockages.
Access is usually common femoral, but contralateral femoral or even brachial might be needed. Crossing total occlusions can be tricky. Chapter 111 mentions reentry catheters, IVUS, to guide the wire, like in figure 111.6.
IVUS helps stay in the true lumen.
Right. Then ballooning predilation to open it up. Post-dilation after stenting to make sure it's fully expanded.
And stent choice. Balloon expandable versus self-expanding?
Good question. Balloon expandables are precise, good for short, calcified lesions, especially at the bifurcation. Self-expanding are more flexible, better for tortuous vessels or coming from the other side. Chapter 111 also mentions that routine dilation of the other iliac artery during unilateral stenting is maybe less necessary than previously thought.
Interesting. What about results? How does endo stack up, according to 111?
Table 111.1 shows success rates for PTA and stenting. For simpler lesions, TASI A and B, technical success is high, good clinical improvement, patency rates are getting closer to surgery, see figure 111.9.
Factors affecting patency.
Hypertension, high cholesterol, kidney disease can hurt it. Getting good flow right away predicts long-term success. For complex TASI C and D lesions, historically, bare metal stents didn't do as well as bypass.
But newer techniques.
Yeah, stent grafts and other advances are showing better results now, even in complex cases. And Chapter 111 introduces the GLAS classification for inflow disease in CLTI patients, another way to categorize and predict.
Complications. Anything specific highlighted in 111?
Mainly access site issues, bleeding, hematoma, pseudoaneurysm, or remote problems like vessel rupture, dissection, or distal embolization. Risks are there.
And post-procedure management. What does Chapter 111 recommend?
Keep up the best medical therapy statins. Antiplatelets like aspirin are standard. Low-dose rivaroxaban might be considered for secondary prevention in some. The chapter also defines what counts as significant clinical improvement Beta-Rutherford category, plus a jump in ABI, and it defines patency criteria.
Okay, arterial covered. Let's move down the leg. Section 4, infranguinal disease management, chapters 112 and 113. What's the overarching theme here?
Chapter 113 really emphasizes a multimodal approach. It's not just open or endo, it's often a combination, plus crucial medical management. Endovascular therapy is a key player now, often complementary to surgery.
And the indications for intervening below the groin, chapter 113 again.
Medical therapy first, always, especially for claudication. Smoking cessation, statins, ACE inhibitors, antiplatelets, maybe low-dose rivaroxaban.
So intervention for claudication is only if medical therapy and exercise fail?
Generally, yes. For lifestyle-limiting symptoms despite best efforts. Imaging like CTA helps plan if you intervene. But treating claudication isn't really about stopping progression to CLTI.
But for CLTI itself, Rutherford 4 to 6.
Then it's different. Aggressive, timely intervention is needed. The question isn't if, it's how. Open bypass or endo first? That's the basal trial question.
Right. So if open bypass is the choice, chapter 112 covers exposures and conduits. Briefly.
Standard exposures for femoral, profunda, popliteal, tibial arteries. Conduit choice. Autogenous vein, especially great saphenous, is king. If not available, maybe PTFE prosthetic, sometimes with a vein cuff below the knee. Umbilical vein, heparin-bonded PTFE are other options. Table 112.1 compares patency.
And the bypass techniques in 112.
Reversed vein bypass, arm vein harvest and splicing if needed, or in situ vein bypass where you leave the vein in place and disable the valves.
Before surgery, chapter 112 mentions preoperative assessment.
Crucial. These patients often have lots of comorbidities, diabetes, COPD, kidney disease, CAD. Cardiac assessment is important, though the specifics are debated. Need to evaluate risk carefully.
Okay, intraoperatively for infranguinal bypass, what are key points from chapter 112?
Defining inflow doesn't always have to be the common femoral. Shorter bypasses can work. Need to pick the best distal target artery based on imaging. Figure 112.1.
Vein cuffs for PTFE grafts.
Big patency advantage below the knee, yes.
Yeah.
Figures 112.7 to 9 show that, and completion studies are absolutely vital.
Checking the work again?
Yes. Palpation, Doppler, completion angiogram, figure 112.13, Duplex, maybe angioscopy. especially with in situ or non-reversed veins. Catch problems before closing.
Got it. Now back to endovascular for infrainguinal disease, chapter 113. Sounds like it's often first line now.
For the femoropopliteal segment, yes, especially shorter lesions. But it's a tricky area. Lots of movement, bending, twisting. Can lead to restenosis.
What tools are used? PBA, stents, drug-eluting tech.
PBA balloon angioplasty is still used. Self-expanding stents are common now, especially for longer lesions, because they handle the movement better than balloon expandable ones.
And the drug-coated balloons and stents, DCBs and DES.
Big area. The idea is drug delivery to reduce restenosis. Sirocco trial looked at sirolimus stents. For DCBs, trials like Thunder, Pacifier, Impact, SFA showed they reduce reinterventions compared to PBA or bare metal stents.
But impact on amputation rates?
Less clear, especially just for claudication. And Chapter 113 does mention the recent concerns about paclitaxel safety. That's an ongoing discussion.
What about the tibial arteries below the knee, endovascular treatment there?
It's less clear how much isolated tibial disease causes typical claudication. For CLTI down there, basal showed higher failure rates initially with endo versus bypass. DCBs are being studied, debate SFA. DS results in trials like Yukon, BTK, Destiny have been mixed, sometimes better patency, but not always fewer amputations. Tibial stents still have limitations.
Chapter 113 also mentions hybrid procedures again here.
Yes, combining techniques, like femoral narderectomy for inflow, then endo treatment downstream, or using endo to shorten the needed bypass length if vein is limited. Schanzer's study showed good results with hybrid approaches for CLTI, can also be useful for fixing failed grafts.
And medical management after infrainguinal endo, chapter 113.
Antiplatelets are essential. Aspirin is standard, based on ATC and Cochrane data. Dual antiplatelet therapy, DLPT, often used periprocedurally, but the optimal duration is still debated, balancing benefit versus bleeding risk. VQI data shows it's common. LMOWH versus aspirin for CLTI post-endo is also mentioned.
Okay, let's look at the results of open infrainguinal bypass from chapter 112. What are the key endpoints?
Objective ones are graft patency, limb salvage, mortality. Conduit type is huge. Vein beats prosthesis. Vein quality matters. Poor runoff is hard to define, but vein grafts can sometimes survive despite it.
Age or diabetes impact patency much?
Not significantly per the chapter, though diabetes affects wound healing. End-stage renal disease.
Right.
Does hurt patency, increases limb loss and mortality. Anesthesia type. No clear impact. And remember, today's CLTI patients might be sicker than historical trial cohorts.
Basal trial again?
Yep, showed worse amputation-free survival with prosthetic versus vein grafts in severe ischemia. And bypass after failed angioplasty might do worse. Tables 112.2 and 112.4 summarize patency rates.
What about subjective endpoints? Quality of life?
Increasingly important. Durability, functional outcome. Tissue loss and early graft failure really hit quality of life hard. Basil's follow suggested bypass might be better long-term for fitter CLI patients than PTA first.
And graft surveillance. Chapter 112 stresses this for vein grafts.
Absolutely critical. Serial ABIs and duplex scans to catch stenosis, usually intimal hypoplasia, before the graft clots. There's a recommended schedule, criteria for intervening prophylactically, good evidence, Lundell trial, shows surveillance improves patency and is cost-effective.
But not for prosthetic grafts.
Surveillance hasn't shown the same benefit there, no.
Anticoagulation after bypass.
Chapter 112 mentions warfarin might help in high-risk vein grafts, poor runoff, bad vein redos, but you have to weigh the bleeding risk. Scoring systems like FIN-VSC Prevent the Third, Basal, Table 112.7, can help assess risk.
Okay, we've covered diagnosis and treatment thoroughly. Now, the final section, Section 5, amputation. Chapters 114 and 115. This is tough, but essential.
It is. Chapter 114 starts with epidemiology. Trends show some decline in non-traumatic diabetic amputations in the U.S., which is good.
But disparities persist. Ethnicity, socioeconomic factors.
Huge impact. Chapter 114 highlights higher rates in Black populations, likely due to complex factors like healthcare access, comorbidity management, lower income, lack of insurance, also linked to higher rates. The ACA's impact, variable. Regional differences exist too.
And the choice between primary amputation versus trying to revascularize.
Varies a lot by hospital, surgeon experience. Predictors for primary amputation often include diabetes, kidney failure, severe tissue loss, poor functional status beforehand.
But amputation isn't always a failure, right?
Exactly. Chapter 114 makes that point strongly. It can be a valid rehabilitative option. For some patients, like younger ones getting a BKA, functional outcomes might be similar to successful limb salvage. Reasons for amputation include non-reconstructible disease, failed bypasses, severe infection, intractable pain, or a useless limb.
Perioperative management for amputation is key. Chapter 114 on minimizing risks.
Mortality risk is real, especially for AKAs. Predictors include kidney failure, heart issues, sepsis, COPD, steroid use, age, complication risk tied to sepsis, alcohol, steroids, cardiac renal disease, infected wounds.
But major cardiac events may be lower now.
Likely due to better medical management statins, beta blockers. Chapter 114 also discusses aggressive infection control, two-stage procedures, cryoamputation for severe infections in high-risk patients.
A critical decision, amputation level. Chapters 114 and 115 guide this. What are the goals?
Remove the bad tissue infected, dead, painful. Get the stump to heal. Create a functional residual limb for prosthesis fitting.
And level impacts rehab potential.
Big time. More energy needed for AKA prosthesis versus BKA. BKA generally leads to better prosthetic use and ambulation rates. Minor amputations like toes, minimal energy impact.
How do we objectively assess healing potential at a certain level? Chapter 114.
Several methods. ABI gives some info. Lower ABI in non-revascularized CLI predicts higher amputation risk. Radioisotope scans, xenon, TC99 meter have been tried. TC99 meter might help guide level selection.
Transcutaneous oxygen, TCPO2.
That's a common non-invasive tool. Thresholds vary, but generally 40 milliliters G is good, 20 milliliters G is poor. No absolute cutoff, though. Infection, edema can affect readings. Importantly, these tests supplement clinical judgment. They don't replace it. TCBO2 might also predict revascularization success.
Chapter 115 then details the different levels. Can you quickly run through the main ones?
Sure. Toe amputation for distal lesions. Ray amputation, toe plus metatarsal. Transmetatarsal, TMA, for forefoot issues, allows near-normal walking, maybe need Achilles lengthening. Midfoot, Lisfranc, Chopart, need orthotics. SIME is ankle disarticulation.
Knee.
BKA or transdubial. Various flaps, posterior burgess, skew person, sagittal. Need adequate bone length, good muscle coverage, myodesis, myoplasty. Careful closure through knee is an option.
And above knee.
AKA or transfemoral. Specific flaps and muscle stabilization.
Finally, post-op care and rehab, chapters 114 and 115 cover this. What's crucial?
Immediate care. Wound dressings, protection, DVT, prophylaxis, antibiotics. Then a multidisciplinary rehab team is key.
Stump management.
Edema control with compression, pain management, incisional and phantom limb. Wound care, psychological support, very important. Dressings can be soft or rigid. IPOPs, immediate prostheses, might help early mobilization.
Prosthesis fitting and functional outcome.
Meet a good prosthetist. Success depends on pre-op mobility, age, health, mental status, amputation level, healing, unilateral versus bilateral status, rehab adherence. Depression is common, needs screening and support. K-levels, table 115.2, classify functional potential.
And potential complications post-amputation, chapter 115.
Local ones, bleeding, higher risk with antiplatelets, but DVT prophylaxis still needed. Infection, pain, phantom, residual limb. Wound healing problems, systemic. Cardiac events, MI is a common cause of death. Pneumonia, DVT-PE.
Wow. We've covered a tremendous amount, a real deep dive constructing that instruction manual for LECAD from Rutherford's.
Yeah, it's been comprehensive. From the basics of prevalence and risk factors in 107 through diagnosis, the details of arterial and infraguinal treatments, both open and endo in 109, 111, 112, 113, and wrapping up with the critical aspects of amputation in 114 and 115.
And the big takeaway really seems to be individualized care, doesn't it?
Absolutely. You have to tailor everything, diagnosis, treatment choice, goals to the specific patient, their clinical picture, their health, their anatomy, and what they hope to achieve functionally.
And the field keeps changing. Chapter 115 hints at future directions.
Things like AI possibly helping predict amputation levels, ongoing advances in prosthetic technology. It's constantly evolving.
So, a final thought for everyone listening. With endovascular tech and prosthetics advancing so fast, how do you see the management of severe LECAD changing in the next, say, 10 years? Or maybe, considering those socioeconomic disparities we talked about, what systemic changes could actually lead to more equitable outcomes for PAD patients?
Good questions to ponder. We definitely encourage you to go back to Rutherford's, explore these chapters further, and keep up with the research. Thanks for joining us on this deep dive.